I want to thank Dr. Tamokiat for the kind introduction. I would also like to thank AOSOR and VSRNM for the organization to let me have the chance to be here to join the conference. So today I will talk about the management of pulmonary nodule. It is often, not quite so often, that we always encounter reading the CT by the, we can see many pulmonary nodules. Some are ground glass nodule, some are solid nodule, while the other could have the shape of polygonal, such as this one. The other could have an ovoid shape. And some have a margin of irregular, either spiculated or lobulated. Internal content, it could be having air bronchogram or calcification. They all can be cancers. But having to follow up these very often will give the patient many radiation. So, what feature predict the benign diagnosis? And we do not have to offer the follow-up for them. And what nodule we should follow up with CT? And for what nodules do we have to perform other imaging? And more advancedly, when should we provide the option of non-surgical biopsy? So we need guidelines to have a uniform consensus to offer this kind of options. There are many guidelines regarding the management of a pulmonary nodule. Flexural Society have published guideline in 2005, 2013, and 2017 with progressive newer evidence. American College of Chest Physicians also published several clinical practical guidelines. And the British Thoracic Society also published guideline in 2015. The thing that we should notice is that there are different role of detection and apply of this guideline, such as Flexural Society apply only to the incidentally found nodules. They do not apply to the screening detected nodule. While the other two guidelines, they apply to both incidentally detected nodule and screen detected nodules. And Flexural Society guideline apply only to patient that is 35 years or older, while the BDS guideline apply to those who are 18 years or older. So, as the Flexural Society is more bounded to radiology, and its recommendation is most based on the image findings. So, I will focus on the Flexural Society guideline as the main content of today's talk. We should notice that Flexural guideline is not intended use for patients with known primary cancers and are at risk of metastases, and also not for immunocompromised patients who are at risk for infection, because those infections could also manifest as multiple pulmonary nodules. The guideline have recommended that if we found a nodule, the subsequent CT follow-up should be performed with lower dose CT scan, which recommended to have a CT DI volume of less than 3 milligray. And in thin section reconstruction by being 1.5 millimeter or less, and performing reformatting in coronal and sagittal plane and also archive in the system is also recommended. So the next one is we perform decent images. Then what are benign lesions that we can safely call, oh, okay, probably you don't need follow-up. The Flexion Society have mentioned that a smoothly marginated solid nodule with lamina calcification or nodule with internal fat and calcification as favoring benign lesions, while BTS added diffuse, central, and popcorn calcification additionally. Regarding the location of the nodule, those located in peripheral area, some of them will favor benign lesions, and a routine follow-up for these nodules is not needed. As the previous slide has said that calcification and fat is important for calling benign lesion, benign finding. So the attenuation measurement is quite important here. For attenuation measurement, use non-sharpened images, such as those reconstructed with standard kernel or soft tissue kernel, because those with sharpened kernel will erroneously result in erroneous high attenuation. Also use small region of interest to measure attenuation, not point measurement. Regarding solidity and size measurement, nodule could be categorized as solid nodule and subsolid nodule. Subsolid nodule also can be divided into pure ground glass or post-solid nodule. The meaning of a non-solid nodule would be hazy, increased attenuation in the lung that does not obliterate the bronchial and vascular margin. We can see through the lesion to see the underlying vessels and bronchus. A solid nodule will refer to the homogeneous soft tissue attenuation nodule. And post-solid nodule having both ground glass and a solid component. So regarding the size measurement and calling that there is a solid component, use age enhancing, which is sharp filter, to do this. But quite often we can see that this ambiguous situation. We can see these images, there are eccentrically slightly higher attenuation in the periphery of the nodule, which is most ground glass. Some radiologists would call it post-solid nodule, others could call it ground glass nodule. The agreement is only moderate. So, is there any other method of assigning post-solid category? Some authors would propose that partially invisible when viewed on mediastinal window reconstructed with thin section and sharp kernel would fit the post-solid nodule. The other quantitative method, consolidated tumor nodule, is also widely used to quantify the degree of post-solidity. Regarding size measurement, that please use sharp filter and use long window to measure the lesion. Axial, coronal, sagittal plane both can be used to measure the size. But we just use the image having the greatest long axis diameter and measure the long axis and short axis on the very same images and average these two values and round it to the nearest whole millimeter. And do not measure micronodule, which is less than 3 millimeter, and exclude speculation from the size measurement, as we do the measurement For the image, we measure as the white dotted line instead of the red solid line. For the solid component measurement in a part solid nodule, we use the maximum diameter of the solid component and only measure it when it is larger than 3 millimeters, because sometimes the vessel and the solid nodule, it looks very same. We don't know if it's actually a vessel or it's a solid component. So only measure those larger than 3 millimeters. So growth. Size change threshold by at least 2 millimeters, we call the tumor growth. And regarding the peripheral nodule and the nodule with peripheral location, we can see these three images look quite same. They are all located in fissure region. But the left one turned out to be intrapulmonary lymph node. The middle one turned out to be minimal invasive adenocarcinoma. The right one turned out to be invasive adenocarcinoma. But we look the image more detailedly, we can see the first one there is slightly convex at the fissure side of the nodule. And the next one, there is a slight indentation here. And more look detailedly, we can also see probably a ground glass component in this side. And for the left one, we can see the more pronounced indentation at the fissure. And the opposite side, there are speculations. So there are subtle differences between these nodules. And the typical peripheral nodule, PFN, is specifically for the homogeneous solid nodule attached to a fissure with a lentiform or triangular shape. How the nodule shape influenced by the fissure is a pretty important factor that we can safely call it's PFN, or it's just a nodule at the peripheral location. So let's advance to the management, which consists of a series of criteria, which sometimes seem not interesting, but it is guidelines. So the mutual consensus of these guidelines will result in better consensus or communication between the patient and the clinicians. There are same concept of solid nodule management workflow. We first divide the nodule into the small, medium, large size, and there's corresponding management. Small size, we don't offer follow-up. Middle size, we offer CT follow-up, and large size, we offer advanced investigations. Let's look at a single solid nodule. When the nodule is less than 6 millimeters, we exclude it from the routine CT follow-up unless the nodule is with high-risk features such as the speculation or the location is at the upper lobe. And we can follow it at 12 months or even sooner if the scan is suboptimal or the patient is nervous. As the previous slides has mentioned about high risk, let's take a look at the risk estimation and risk model. Certain characteristics are associated with low risk, such as young age, less smoking, smaller size, regular margin, and not at the upper lobe, while the opposite will have associated with high risk. But how about an old patient who never smoked, have a small size of nodule, but have irregular margin? Is it high risk? Sometimes very difficult. So if there are quantitative methods to help us a decision, it sounds good. The risk model, Mayo Clinic model, and Herder model are recommended in the flexion guideline and SCCP guideline. There are formulas consisting characteristic and the corresponding respective weighing factors. We can calculate the probability of a malignancy. Malignancy probability of less than 5% are categorized as low risk, and 5 to 65% as intermediate risk. Those larger than or more than 65% are high risk. And Fletcher Society recommended to integrate the intermediate and high risk into a high risk group. So by this, there's some assist to quantitatively, but we should notice that external validation and extrapolating is, we should notice there probably will be local regional difference. For medium-sized nodule, low-risk patient, we don't offer we offer follow-up at 6 to 12 months, and for high-risk patient, CT at 6 to 12 months, and also at 18 to 24 months. For larger solid nodule, we offer 3 months follow-up CT, PET-CT, or tissue sampling. How about multiple nodules? For those without high-risk features, no routine follow-up. Those with high-risk features, follow-up at 12 months. And for the most suspicious nodule that is larger than 6 millimeter, we use a shorter-term follow-up at 3 to 6 months, and then optionally at 18 to 24 months. Subsolid nodule is sometimes risky of becoming a tumor. So generally, for a smaller tumor in high risk, we offer 2-year and 4 years follow-up. For those larger than 6 millimeter, we follow it firstly at 6 to 12 months for persistence, and then every 2 months until 5 years. This is because a pure ground glass nodule average takes 3 to 4 years before establishing the growth or to be diagnosed as developing invasive carcinoma. Is sooner follow-up than 12 months okay? Sometimes, if patients are comfortable with waiting 12 months, because many of these lesions either will resolve or show no change as sooner follow-up, the patient could be reassured by the CT evidence of being short-term stability. Parsolid nodule, also small, no routine follow-up. For medium size, follow it at 3 to 6 months, and then annually for more than 5 years. For those with even larger solid component, parsolid nodule, first evaluate it short-termly, and if it persists, it is highly suspicious. Then aggressive investigation should be offered to confirm if it's malignancy. And multidisciplinary conference may help to choose the proper method of the tissue sampling diagnostic procedure. And if we see a pulmonary nodule in an abdominal CT, do we have to perform a partial scan covering only the lower part of the tumor, lower part of the lung? No, just either we don't offer further investigation for small nodule, or we follow a complete CT in 6 to 12 months. Or for larger tumor, directly immediately perform a full chest CT to confirm if it's malignancy. So regarding other guidelines, there are several differences, such as use PET-CT to use a risk model to judge when to perform the PET-CT. And the BTS guideline focused on the measuring the size by the volumetry and the growth rate to categorize the risk of being malignancy. So the measurement could be based on the different growth rate by different volume doubling time. So use the same reconstruction technique for comparison and use recommended measurement technique consistently and compare with last and even the earliest CT available. And lastly, as CTSR is hosting AOCR next year, so wish we can meet in Taipei. Thank you very much. Thank you.